Hi everyone, my name's Annalise and I'm going to introduce my IRB proposal topic to you. My topic is vitamin C deficiency and osteoporosis. I'm a fan of vitamin C, especially citrus fruits, hence the orange. I hope you enjoy. Thank you. So first we're going to start with my hypothesis. So, Eureka! My hypothesis is that vitamin C supplementation will improve osteoporosis disease in postmenopausal women between the ages of 50 and 75. Vitamin C intake has been positively associated with bone mineral density values, and it has been associated with a 33% lower risk of osteoporosis and higher bone mineral density. Also, I chose Caucasian females because Caucasian females are more likely to have osteoporosis disease than other ethnicities in America. Now we're going to move on to the wonderful vitamin that is vitamin C. Vitamin C. So, it is water soluble, it has a low toxicity, and it's a major antioxidant. So, the 500 milligrams, by the way, on the other slide, was actually selected on purpose because clinical studies revealed that is the recommended amount to achieve health benefits. And also, since vitamin C is water soluble and has low toxicity, the most common side effects that you would ever see in an excessive intake of vitamin C is GI disturbances such as nausea, diarrhea, or cramping. So because of that, we chose a time-released vitamin C supplement of 500 milligrams to avoid that situation from happening. Now, vitamin C is also called ascorbic acid. Humans are unable to synthesize vitamin D, sorry about that, so it is dietarily essential. It is an important antioxidant. It's been proven to affect bone health positively, and it even can help out other antioxidants such as vitamin E. It can help regenerate vitamin E. Also, vitamin C can limit the damaging effects of free radicals, which are oxidative stress, never good, usually linked to cancer and other really bad problems or diseases. Vitamin C comes from a lot of fruits and vegetables and foods. You can get it in even potatoes. Great potato famine. That was caused because they lost all their potatoes and then henceforth got scurvy. I'll get to scurvy in a moment, but first, I just wanted to say oranges, lemons, limes, grapefruits, strawberries, guava. There's a bunch of great fruits and vegetables that have vitamin C in them. Now, scurvy is a deficiency in vitamin C. It is not a good thing. It actually causes musculoskeletal symptoms, like my friend the pirate up there. He's like, what's going on? Because he was sailing from England, trying to find the new world, and all of a sudden he had collagen problems with his joints and everything, and his bones were not doing well. So because scurvy is responsible for structural collagen alterations, defective osteoid matrix formation, and increased bone resorption. Sounds a little bit like osteoporosis, which we will be talking about on the next slide. Osteoporosis. This is a disease in which the density and quality of bones are reduced. Bone resorption in excess. The name itself literally means porous bone. If you can see here, our healthy bone on the left has a lot less holes in it because we don't want a lot of pores in our bones because they will break easier. As bones become more fragile, there's a risk for fracture that's increased. You hear about somebody breaking their hip or, their lumbar region of their spine, they have a fracture, probably because of osteoporosis. In America, there are over 10 million people with osteoporosis, and 8 million of those are women. I'm sorry, ladies. We don't deserve this. So, and also over half of Caucasian women, 50 and up, are expected to have low bone mass. That's why that was the selected population. Also, postmenopause. Estrogen, great hormone, protects our bones. As soon as menopause comes into play, bone protection is no longer apparent. And good thing, vitamin C is associated with bone health. That's why we chose vitamin C here. Also, T-scores are actually how you assess or diagnose osteoporosis. That will be explained later. Now we're going to move on to inclusion and exclusion criteria. Okay, so you already know that I'm choosing females who are Caucasian, 50 to 75, postmenopausal, and have osteoporosis. Now, I don't want smokers. So as you can see in the exclusion criteria, there is smokers, alcoholics, and also people who take in excessive amounts of vitamin C. Well, smoking and alcoholism can cause absorption issues, and this is all about absorption of vitamin C to improve bone health. We don't want absorption issues that increases complications. Excessive vitamin C intake. That could make the supplementation of 500 milligrams a day invalid because they're already getting a lot of vitamin C. And also premenopausal. If your estrogen levels are good, you're going to have better bone mineral density still. So now that we've covered inclusion criteria, we're going to move on to our participants. How did we get that number? That sweet number. Okay, so participants or subjects. Since this is an IRB study, I will be referring to my participants as subjects. Now, so the number is 688. I use statistical calculations to determine that number. I used the level of significance, power of study, expected effect size, the event rate in the population, and standard deviation. Moving on from that, following inclusion criteria, all subjects will be asked to complete an initial questionnaire. Now, this is very important because this is where the research team is going to find out about the diet, about the medications, the dietary supplements that the subjects are taking in, and also a description of their daily and weekly exercising habits. So subjects will be asked to provide a 3-day diet journal, a list of current medications, a list of current dietary supplements, and let me just add, calcium is expected in at least 1,200 milligrams a day since they have osteoporosis. And also, we want to know what are their daily and weekly exercising habits. These factors are very important because medications, supplements, exercise and diet, if they're having excessive calcium, excessive vitamin C, that can affect our results. So we ask for them to maintain consistency for the duration of the 6-month study so that bone mineral density and results are not affected negatively. Now moving on to research methods and consent for our subjects. So research methods. So we're going to be testing bone mineral density, as that is the most comprehensive and the best way to diagnose osteoporosis disease. The subjects will first be educated on every aspect of this study. They will receive their first consent form, and then the initial bone mineral density screenings will occur. This will all be on, say, for example, day 1. So basically, 2 tests will be performed. The DXA, or dual energy X-ray absorptiometry, and then the PDXA, or peripheral dual energy X-ray or absorptiometry. The DXA will measure bone mineral density in the, I always get these two mixed up. I do not understand why I do. It's silly. We'll be measuring the hip and the spine, and then the PDXA will be measuring the lower arms, wrists, fingers, and heels, all areas where osteoporosis can affect bone mineral density. So after that, subjects will be asked to return after a few days because obviously results and going through results takes time. Sorry, I forgot to add that The DXA and PDXA tests are non-invasive, painless. They take 15 minutes, and there's also minimum radiation, which is also very important. And so a few days later, they will come back. They will then start the 500 milligram supplementation procedure. This is where they will start that 6 months. And of course, before starting, they will also do a consent form and be educated. After that, there will be a 6-month follow-up. This is where we will do our final DXA and PDXA test to see if the vitamin C supplementation worked. Now moving on to confidentiality, which is also very important. I'm sorry, not confidentiality. I'm going to explain briefly the T-scores used. So, as you can see here, green is good. Green would be a normal bone density. Yellow is low bone density, and red is osteoporosis. So in initial bone scan, we want to see negative 2.5 or lower. And then in the final bone scan, we want to see between negative 1 and negative 2.5, basically any sort of improvement. Okay, moving on. Confidentiality, very important. All subjects will be provided with identification numbers so that their identification is not known. All data will go into the Oracle Clinical Database. Each ID number will have a number, first a number from 1 to 688, then an alphabetical letter, 4 zeros, and then the birth date. So for example, subject 1 would be 1A, 4 zeros, and then 15 since they were born on the 15th per se. Data analysis, also very important. We got all the data. How are we going to review it? So we have descriptive and inferential statistics. As you can see here, we used a lot of the common statistical measures. Standard deviation is very important to see if did our results deviate from what we initially started with. Pearson's R correlation coefficient. Is there a positive relationship between bone mineral density and vitamin C supplementation? T-test. Is there a difference between our initial bone scans and our final bone scans? And then qualitative analysis, really assessing the data and formulating a very good, and understanding of all the data compiled. Expected results and limitations. Our expected results are that there will be a positive relationship between vitamin C supplementation and bone mineral density, or osteoporosis, that basically the vitamin C supplementation will improve T-scores. Limitations, there's always those. There could be a lack of reliable testing to know if our subjects are actually postmenopausal. However, if they have osteoporosis and and estrogen obviously has been decreased because they have osteoporosis, most likely we're not going to worry about that. There could be a lack of funding. There could be a lack of there's been a lack of consistent literature. Some studies say that there's a really big relationship between vitamin C and bone health, and then others say it's not sure, it's only in males. So there are some gaps that hopefully will be filled. Finally, remember when I talked about potatoes earlier? Well, potatoes are actually a source of vitamin C, and during the Great Potato Famine, over 970 skeletons were found to have scurvy, and it caused bone deformities. So that right there, for me, is clear evidence that vitamin C does affect bone. And it will most likely cause, improve osteoporosis, as there's, vitamin C helps repair bone and bone damage caused by osteoporosis. And I do believe that vitamin C has a future, as it is a great vitamin. A lot of people love vitamin C enriched foods. A lot of people associate vitamin C with positive health. So on that note, thank you so much for watching my presentation, and I hope that you enjoyed it and learned some valuable things about vitamin C and osteoporosis. And thank you.